It's great to be with you today. This gives us an opportunity to talk about Wahiawa General Hospital and telestroke. Could you do a little introduction of yourself?
Sure. My name is Ellen Kilbasa. I'm a nurse manager for the emergency department.
Great. And registered nurse?
Yes.
Okay. Been in the trenches, right?
Yes, longer than in management, but.
Tell us a little bit about the problem of managing acute stroke in a small rural hospital.
We are about 25 miles from the center of Honolulu, and so that can be a 20-minute ride or it can be an hour ride. If what I'm hearing from EMS depends. We get a lot of walk-in patients that are quite acutely ill, including with stroke. And the challenge for us prior to telestroke was we get a patient that is brought in by their family, they're having a stroke. The first thing we do is get the last time known to be well, and from that time we basically have 3 hours if we're going to opt to give the clotbuster TPA or decide that they need surgery or what is the best options for them according to the physician. So it was a challenge to get that time frame, get treatment within that time frame. Because of the distance from town and not having neurologists in-house. Mm-hmm. And that's the big challenge is for all community hospitals basically is not having the specialist in-house to be able to give the expertise, the expert opinion. So now that we have the telestroke system, some of those challenges have been taken away.
Mm-hmm. When you first started talking about the telestroke system, what were your expectations of it?
Well, it was our first encounter with having anything, telemedicine of any sort, and we were hoping that it would be a quick turnaround for the patient. Mm-hmm. We had TPA here prior to the telestroke, and we did use it, but the physicians were very happy to know that there's going to be an expert that's going to consult with them and help them make a best decision for the patient. Mm-hmm.
Tell us a little bit about how the telestroke system has impacted your ability to manage these acute stroke patients.
Patient comes in the door, whether they come in by EMS or they come in with their family. The NIH stroke scale is looked at right away. You determine, is this patient most likely having an event? If they are sent immediately to the CAT scan. And a stroke code is called by our physician to Queen's physician. We tell them this is a stroke code. Within a very few minutes, the neurologist is online with our physician. Mm-hmm. He's giving them kind of a rundown of what the case looks like so far. They either beam the CT image to Queen's, or the doctor looks at it here at Wahiawa and gives an opinion. Is this a non-hemorrhagic or hemorrhagic stroke? And they make the decisions very quickly. The stroke cart is taken to the bedside as soon as the patient comes back from the CAT scan. We get it going so that the neurologist can see the patient and assess them, and the patient and the family can see the physician at Queen's, and they can talk about history and those kinds of things that need to be done to make a good decision. Mm-hmm. And then as soon as that is done, we have the TP ready to give or not, depending on what the opinion is and what the results of the CAT scan. And even if we have to wait, perhaps Queen's is full too, we've got to wait a little bit to get the patient transferred or whatever, that's okay. Because the treatment has already started. Yeah. Yes.
Excellent, excellent. Now that you've got a little experience with the telestroke program, thinking into the future, what enhancements would you like to see?
Well, we have challenges with all the different specialties. We have surgery here, we have, urology, we have some things here, but the two big challenges were neurology and psychiatry. Okay. We have a big problem throughout the state, of course, with lack of psychiatric services, lack of psychiatric beds. These patients are often have multiple diagnoses, and it's not a clear-cut issue. So they have to be seen by a psychiatrist, as well as the legal issue. If they're brought in on a legal hold, or if they have to be made a legal hold because they're at risk of harming themselves or others, they have the right, and we need for them to have a psychiatry consult. before they are released. And when that's the case, it's a very big challenge to get them to a hospital that has those services in a timely manner.
Ellen, thank you very much.